touch upon things which I feel may be important in the management of atrial fibrillation. So as already been shown by Dr. Nambudri sir, I think we have a new modality for managing patients with atrial fibrillation, which is cryoablation. So as we all know, AF is a progressive disease. We have been hearing about arrhythmias since last 45 minutes to 1 hour. We have heard about a lot of arrhythmias like atrial tachycardias, AV nodal re-entry, or pathways which are due to connections between atrium and ventricle. And one different thing about atrial fibrillation is the progressive disease. A patient who had an AV nodal re-entry some 20 years back was managed medically, comes to you for an AV nodal re-entry ablation. It hardly changes your outcome or the procedural success or procedural complications because the arrhythmia remains same. But atrial fibrillation, if you see a patient with atrial fibrillation who has got into atrial fibrillation some 10-15 years back and comes with the atrium of 60 millimeter, you hardly will be able to deliver anything for this patient. Because a patient with proximal atrial fibrillation with a non-dilated left atrium has the best results. Because of all this, you have a lot of things which is going into the left atrium when the patient has atrial fibrillation. So atrial fibrillation, which starts at the proximal atrial fibrillation, during every episode, there is a atrial remodeling. A lot of structural changes happen in the left atrium. So patient slowly progresses into a proximal to persistent to a permanent atrial fibrillation. Why we have to be worried? Because treatment changes. There is a significant outcome changes when the patient progresses from paroxysmal to permanent atrial fibrillation. So, one of the largest study, Rocket AF, where the patient were followed up for a atrial fibrillation. Around 18% had a proximal atrial fibrillation. Around 82% had a persistent atrial fibrillation. When they looked at both the curves, you can see the curves are diverging very early and very far away. So, there was a significant increase in all-cause mortality. There is significant increase in stroke, and a composite endpoint of stroke, systemic embolism and death was significantly higher when the patient has progressed from proximal to permanent or a permanent form of atrial fibrillation. So, this is what happens when the patient progresses. You have a 2.5 times increased cardiovascular event rate, 6.5 times more prevalent of stroke, and 2.5 times more increase in heart failure, and 1.5 times more increase in hospitalization, and definitely you have a health related quality of life which significantly goes down when the patient moves from proximal to permanent form. We all know one of the largest study, AFFIRM study, which showed that rate control and rhythm control curves hugged each other and closely followed, and slide move on. Close it down. Move. Yeah. So you can see both curves are closely to each other. This is what put all of us into a notion that rate control should be as good as rhythm control. The problem here was when you go in and see deep into the study, when you keep the patient in sinus rhythm for a atrial fibrillation, that is a rhythm control arm, there was significant 50% lower risk of death. The problem is the way you keep the patient on sinus rhythm. When you are using high dose antiarrhythmics or antiarrhythmics which are toxic to keep the patient on sinus rhythm, you have increased the mortality by 50%. So, the sinus rhythm was good. The problem was the way you keep the patient in sinus rhythm. If you are going to use antiarrhythmic for the modality for keeping the patient in sinus rhythm, there is a possibility that you will not enjoy the benefit of keeping the patient in sinus rhythm. So, rhythm control, who are the patient you will prefer for rhythm control? The patient who are younger, less than 65, a patient who presents with a tachycardia-induced cardiomyopathy, a disabling atrial fibrillation symptoms, a patient who are at the risk of stroke, AF with a recurrent transient ischemic events, who are not able to achieve a rate control, pregnant patient, no or minor structural heart disease, no or few comorbidities, normal or only moderately enlarged LA, a patient who have a heart failure, and patient wants rhythm control. You have a rhythm control strategies. One of them has already been explained in detail by Dr. Ajit. direct cardioversion. You have drugs which are going to be discussed in detail in the next talk. You have flecainide, propafenone, sotalol, dofetilide, amiodarone available in India, while dronedarone is not available in India. These drugs can be used. Class 1C drugs have a excellent efficacy. Only problem is you have to use them ideally in a patient who does not have a structural heart disease or coronary artery disease or does not have an LVH. Sotalol can be used in most of the patients except for a QT prolongation. Amiodarone is a drug which can be used in most of the patients. The problem is long-term toxicity. So that's the reason most of the guidelines have started recommending ablation for atrial fibrillation early. If you have a patient with symptomatic AF, refractory to antiarrhythmics, proximal atrial fibrillation, catheter ablation is class 1 indication. Persistent AF is a class 2A indication. When you have a long-standing persistent, still you can try, it's a class 2B. For a patient, there's another recommendation. You have a symptomatic atrial fibrillation. You have not started an antiarrhythmic drug yet, but before that, you can consider a patient, even on patient who was on beta blockers. Here, the recommendation is class 2A for a proximal atrial fibrillation and persistent atrial fibrillation. For a long-standing persistent is a class 2B. That means a patient who was on antiarrhythmic, recurs with antiarrhythmic, if it is a proximal atrial fibrillation, it's a class 1A. And if you have a patient with a symptomatic AF, even before you want to initiate an antiarrhythmic, still consider a catheter ablation if it is a proximal atrial fibrillation. This is how you treat a patient with atrial fibrillation if you are looking at a rhythm control as a strategy. If a patient does not have a structural heart disease, you can use flecainide or propafenone. And if patient wishes and you are interested, you can use catheter ablation as a primary strategy. If this fails, you can consider amiodarone. If a patient has a structural heart disease, a coronary artery disease or a heart failure, your options are limited. Only drug most of the time you will end up using is either sotalol or a amiodarone. And if this fails, you can consider catheter ablation. So, catheter ablation has two options. One is what we use as a point-to-point ablation, otherwise called radiofrequency ablation, or you can use a cryoablation. In our center, we use cryoablation, as Dr. Nambudri sir has already shown you. Cryoablation is a technique by which we achieve a pulmonary vein isolation. It's an anatomical approach. It delivers a good, long-lasting pulmonary vein isolation. So this is how we do it. Hopefully, please. Yeah. So if you look at a cryoablation, the primary technique is we go across septum transeptally, go from a femoral vein, take a transeptal axis, go into pulmonary vein. Once you enter the pulmonary vein, we record what is there in the pulmonary vein. We record the signals in the pulmonary vein. We know one of the common reasons why patients with atrial fibrillation develop atrial fibrillation is the firing or arrhythmogenic focus inside the pulmonary vein. We try to isolate pulmonary veins electrically from the left atrium. We put a catheter inside, record the potentials inside the pulmonary vein. Once you know you are inside the pulmonary vein, we take the cryo balloon. The cryo balloon is taken inside. We occlude the pulmonary vein. We check how well we occluded the pulmonary vein. Once you occluded the pulmonary vein, we deliver a cryo energy. Once you start delivering cryo energy, you can see how the pulmonary vein gets isolated. There's another picture on the side where you can see some electrograms are shown. Few electrograms have been already shown. Whenever you see a recording from the pulmonary veins, you will record something called a pulmonary vein potentials, which are marker for electrical activity inside the pulmonary veins. When you start freezing, then you will see that pulmonary veins are getting isolated from the LA endocardial tissue. So you know you have achieved a good pulmonary vein isolation. So this pulmonary vein isolation by a cryoballoon is long lasting. So a lot of studies are there which have shown that when you have done a pulmonary vein isolation with a cryoballoon, and when patient gets an AF recurrence, you go and check your pulmonary veins. Most of the time they are totally isolated. The AF is coming from some other location. So this is how it is done. So cryoablation is better in compared to radiofrequency because it offers some unique advantages. Shorter procedure time. You preserve a extracellular matrix, thereby reduce the incidence of thrombus, and your as I told you, your cryo balloon induced pulmonary vein isolations are long lasting. So already we have seen some cases, so I'll not go into detail. This is how it looks like when you do a pulmonary vein isolation. You have electrically connected pulmonary veins with LA. The moment you do a isolation, you can see gray areas which are extending from the pulmonary vein ostium into the LA. One other good thing you see with pulmonary vein isolation by cryoballoon is you take care of good amount of posterior wall of left atrium. We all know posterior wall of left atrium can be arrhythmogenic in patients with atrial fibrillation. Because cryoballoon, the balloons are bigger, 28 millimeter balloon. When you deliver a cryo energy, a significant portion of posterior wall also gets isolated from the pulmonary vein along with pulmonary veins. So you get a better results than a radio frequency ablation where you deliver a antral isolations. So this is the reason why single procedure freedom from ATAF or AFL across globe has been pretty good. There are centers which are reporting success rate as close to 90% across the globe. This is another reason why the global numbers for cryoablation have significantly gone up. Now we have more than 100 literature peer-reviewed journals which quote cryoablation as a therapy. More than 14 years of experience, and in India we have experience close to 2.5 years now. And around 80 plus countries along with India now using cryoballoon as a source for energy for doing a pulmonary vein isolation. So this is how you do AF management in present times. You can have a permanent or non-permanent AF. If a permanent AF which is asymptomatic and heart rates are doing well and patient LV function is okay, you continue with the rate control drugs. If you are not able to maintain a asymptomatic status with the rate controlling drug, sometimes you may have to resort with the AV nodal ablation. If a patient with a non-permanent AF is asymptomatic, you can continue with your rate controlling drug. If the patient is symptomatic, you can move on to a rhythm control strategy where you can use either a antiarrhythmic therapy or a pulmonary vein isolation. If doesn't work, then you can consider in these group of patients also an AV nodal ablation. So this is how AF is managed now. Previously, a patient with a non-permanent or paroxysmal AF comes for a treatment. You will look at the symptoms. You use rate control drugs. If patient is still symptomatic, you will consider antiarrhythmics, and still symptomatic, you will consider ablation. Now, what we are doing, a patient with paroxysmal AF comes with symptoms, you use rate control. If patient is still symptomatic, you will consider adding a rhythm control either with an antiarrhythmic or an ablation. If a patient is still symptomatic, then you can consider either of them. If the patient you have used antiarrhythmic, symptomatic, you use catheter ablation. After a catheter ablation, patient develops recurrent AF or a recurrence of symptom, you use antiarrhythmics. How we are looking at future, if a patient with paroxysmal atrial fibrillation comes, you can use rhythm control as a primary strategy. On rhythm control, you with cryoballoon with such a safety record, which Dr. Nambudiri has already shown, you can consider as a primary mode of ablation. If the patient recurs with rhythm control strategies, then you can use rate control as a last resort. This is for, you should always remember, this is for a proximal atrial fibrillation. We are not talking about a permanent form of atrial fibrillation where your success rate of most of the rhythm control strategies are not good. Why we consider this? Because of excellent safety record of cryoablation. You could see in most of the trials, the adverse reactions with antiarrhythmic therapy and cryoablation are comparable. You could see that 3 and 4%. So, lot of studies have come, and the recent studies have shown cryoablation is superior to antiarrhythmic therapy in prevention of atrial arrhythmia recurrence. First-line cryoablation was associated with a larger improvements in AF specific quality of life compared to antiarrhythmic therapy. More patients were asymptomatic at 12 months post-blanking period in cryoablation arm than antiarrhythmic therapies. So with this, a cryoablation can become a first-line rhythm control strategy with an acceptable safety profile. With this, I'll close my talk. We'll go on with the next talk, and if there are any questions, we'll take the questions at the last. So let me invite Dr. Gamechanger for the next talk. It is about drug therapy for atrial fibrillation, both rate and rhythm.